I'm very grateful to the Foundation for recognizing my work through the Colvin Prize, and specifically thankful to Professor Carpenter for highlighting resilience as an untapped source of potential therapeutic relevance. And my talk will be structured along three themes. First, I would like to share with you some of my thoughts about resilience and why I think it is an important and so far neglected area of research. And then I will focus more specifically on mechanisms of resilience in bipolar disorder, and I will finish off with some thoughts and ideas as to what should be the way forward. So the first thing that I would like to discuss is how we address the relationship between risk, causation, and resilience. The 19th century was remarkable for medicine because for the first time we were able to show within medicine direct causation, particularly in the context of infectious diseases. So we were able to identify specific agents that had a direct link with the clinical outcome. And here I'm giving an example based on tuberculosis for no particular reason. And the connection between the clinical manifestation of tuberculosis and the mycobacterium that causes it is one-to-one. So the mycobacterium is necessary, it has to be present for the person to develop tuberculosis. And if an individual has tuberculosis, then you can be 100% sure that they have been exposed to the mycobacterium. And this type of deterministic one-to-one causation is the type of model that we feel most comfortable with generally as human beings. But life is never that easy, and what we have come to realize throughout the 20th century is that with the exception of infections and few other disorders, the disorders that we are faced with in medicine and in psychiatry are very different in terms of the model that explains them. And they fall into this category of multifactorial models. In this case, we do not have this nice correspondence between one cause and one outcome, but we have multiple risk factors, and we call them risk factors because each of them slightly increases the likelihood of the disease happening, of the outcome happening. So they are neither necessary nor sufficient. And what do I mean by that? We know that childhood abuse increases the likelihood of depression, but in itself, it's not sufficient because there are a lot of people that have experienced childhood abuse that do not develop depression. And equally, it's not necessary. It's possible for somebody to have depression without ever having experienced childhood abuse. So the relationship between the risk factors and the outcomes, it's much more complex than we are used to. The other thing that we have found out is that there are multiple risk factors, none of which is specific for any disorder. In fact, none of which is specific for any psychiatric disorder. And you don't have to read the list because very helpfully Professor McGrath and Professor Brown have given you examples of the risk factors that have been identified for a number of psychiatric disorders. And when it comes to risk factors, there is a very simple rule. Bad things increase the likelihood of other bad things happening. So risk exposures of any kind increase the likelihood of psychiatric outcomes. The issue that we have, of course, with these risk factors is twofold. First, they are extremely common, and that's what you see on the diagram with the bars on the top. This is data from the ABCD study, which is a US-based study that has collected much information on a cohort of 11,000 10-year-olds with the intention of following them up longitudinally. The red bar represents the number of people within this cohort of 10-year-olds that have experienced 1, 2, and so on exposures or risk factors. And the blue bar shows the increasing number of risk factors. And as you can see, the exposure to risk factor is so common that about at least 93% of the entire cohort has experienced one risk factor. So not only they are difficult to modify, They're also extremely common in the general population, but more importantly, they do not always lead to a negative outcome. They just increase the likelihood of that outcome. And in this particular cohort, despite the magnitude of exposure, only a small number of children have actually experienced an adverse mental health outcome. In addition to this type of psychosocial risk factors, we have identified a number of genetic risk factors, and this is what is shown here. Again, there is very little specificity when we look at the common genetic variation for any particular psychiatric disorders. And that's what is shown in the diagram as you look at the screen on your left, that shows the degree of correlation in terms of genetic risk architecture between different psychiatric disorders. And what you can see on the right is the distribution of the genetic burden, and this is just an example, in healthy individuals, which are represented with a blue line, and in patients with psychosis, which are represented with a broken red line. So what is striking, I think, when you look at this particular distribution is its overlap. So there are individuals that have very high risk scores or very high burden, cumulative burden for schizophrenia that remain well, and this is the blue line, and they overlap nearly fully with those of the patients. So we have bad genes and bad events that are happening to people, each of which increasing the likelihood of a negative event, but in themselves, they are not actually necessary or sufficient to produce a clinical symptom. And finally, I would like to comment on the presence of attenuated clinical symptoms, which are often, in many people's mind, considered prodromal, in some way deterministically predicting the negative outcome. This slide is showing data from a study that is a longitudinal study of a birth cohort in the southwest of England. And in this particular study, 4,000 individuals were assessed at the age of 12 with regards to the presence or absence of psychotic symptoms. And they were classified as having none, having some suspected symptoms, and having more or less definite symptoms. And the same individuals were reassessed at the age of 18. So the ones that were well remained well. As you can see, the overwhelming majority of people that were well remained so. But what is interesting is what happened to those with suspected psychotic symptoms, the overwhelming majority of which were able to recover at the point of follow-up, and exactly the same happened, with those that had definite symptoms. Again, the majority recovered at follow-up. And this pattern of recovery, even in terms of attenuated symptoms, it's something that has been replicated in other cohorts, for example, the Philadelphia neurodevelopmental cohort, that also show a resolution of psychotic symptoms at 2-year follow-up in a large epidemiological sample of young individuals. So if we consider all that I just said together, what we have as the model of disease causation that specifies the association between risk and resilience is this one. So we have a number of risk factors. Some of them are modifiable, some of them not. And all of these risk factors may have many different outcomes, psychiatric outcomes, not necessarily one single disorder, but multiple. But in the most common outcome of exposure is actually no disorder or resilience. And here I am giving you the definition of resilience as was proposed by Michael Rutter, who is the British psychiatrist that is traditionally credited with the creation of the field of child psychiatry, and one of the first individuals to recognize resilience, particularly in the cohort of children that have been institutionalized in orphanages as in Romania and in other places. So what he actually describes as resilience is an interactive concept that is concerned with a combination of serious risk and a positive psychological outcome despite the risk. So when we talk about preventing mental illness, and we consider it unthinkable. In my view, in fact, is what commonly happens naturally. Most of us, most of the people in this room, have had multiple exposures, and most of us have been able to overcome them. And the question is, how do we do that? A lot of the models that have focused on resilience have been purely psychological models. They attribute resilience to cognitive or other coping mechanisms. And the question that I was asking myself is that this phenomena cannot happen completely independently of the brain. There must be some mechanisms, some aspects of the brain that support this resilience. And the question is, can we measure them? Can we find them? Can we characterize them? And overall, can we actually use this information for prevention or therapy? The fact that resilience has therapeutic potential has not been demonstrated in psychiatry because, as I mentioned earlier on, we haven't focused on resilience as a source of therapeutic discovery. But in other aspects of medicine, and I'm just giving you two examples, one from cardiovascular medicine and the other one from HIV medicine, a lot of the new treatments that have been identified and are applied are aiming to increase mechanisms of resilience rather than trying to fix or directly address the cause of the disease. So we have concrete examples of therapeutic benefit from resilience in other fields of medicine, and I hope soon in the context of psychiatry. There are many different levels at which we can actually look for resilience. We can look for resilience in terms of genetic markers, epigenetic phenomena, social and psychological phenomena. We can look at cellular alterations that may enhance resilience. But the data that I will show you today comes specifically from neuroimaging. Oops, sorry about that. Comes specifically from neuroimaging and are focused on alterations that we can see in brain organization. Why neuroimaging? Because to some extent, the organization of the brain is directly linked both with cognition and behavior in health and disease, and is the closest we can get to biological mechanisms that can explain this mental phenomena. And next, the other thing that we do know about the brain is that it's plastic. It changes. It changes in response to experience, and it changes in order to overcome different things. So we're looking at adaptive plasticity in the brain as the possible biological mechanism for resilience. The focus on bipolar disorder is because bipolar disorder, I think, is a very unique type of disorder within psychiatry. One of my UK colleagues used to call bipolar disorder the heartland of psychiatry, because patients with bipolar disorder have all the other symptoms combined that you can see in nearly every other of their disorders. They have depression, they have mania, they have occasional psychosis, and they have anxiety. So all the symptoms that you can possibly see in other disorders are present in bipolar disorder. But what I think is most remarkable about this disorder is depicted in this particular diagram. You have seen it very many times, and I think we, to some extent, have lost the sense of awe, I think, behind this particular clinical course. So patients with bipolar disorder can have normal or near normal mood, and then they can go into depression, mania, and variable variation in these sort of symptoms. Now, bipolar disorder is episodic. It means that patients have episodes, meaning time-limited periods during which they experience depression, mania, or euthymia, which means normal mood. And what is interesting, in addition to that, is that these episodes are essentially self-limited in the vast majority of bipolar patients. There are some patients, of course, that have very severe bipolar disorder, and they do not experience remission, but the vast majority of patients experience spontaneous remission. I'm not arguing here against the use of medication to prevent or assist in the quicker resolution of the different episodes, but it's important to note that they do resolve by themselves in the majority of patients. So here you have a phenomenal brain, a brain that can exist in two different states of disorganization and then return back to a normality that is captured by the concept of euthymia. So the ability, the plasticity of the bipolar brain is actually quite remarkable. And therefore, this is a very good place for us to start looking for plasticity-related mechanisms that may account for recovery, but also specifically today for resilience. The other characteristic of bipolar disorder is that it's highly heritable. Here again, you see the degree of heritability of different disorders. This is bipolar disorder, and it has a heritability of about 80%. So 80% of the likelihood of developing this disorder has to do with familial risk. And in that sense, the relatives of patients with bipolar disorder represent a natural group of high-risk individuals, both in terms of their genetic risk, but also in terms of the psychological risk, because they have shared with the patients the same family environment and most of the same early experiences. And therefore, the relatives that remain well are a naturally occurring group of resilient individuals. And so looking at plasticity changes in these individuals can give us a handle into the general concept of resilience-related plasticity. So there are many different ways that we can examine the brain using neuroimaging. And I'm just going to focus here on 3 different types of imaging that we can actually do. The first one is to look at brain structure, the shape of the brain. And we are all familiar with that because having a structural MRI scan is a very common experience, sort of generally. So in terms of thinking of the brain as a computer, the structure is your hardware, is the actual desktop or laptop that you have. So the hardware is the brain structure, and any plasticity that we can see in brain structure is long-standing hardwired plasticity. In addition to that, the brain has a functional organization, and that has to do with the way different regions of the brain interact functionally with each other. And we can have a baseline functional organization, which again, in terms of computer speech, will be your operational system. It's the basic parameters that characterize the functional characteristics of your brain. And on top of that, we have connectivity that is related to specific tasks. And coming back to computer speech is like running a software for a specific program. So you have your hardware, you have your Windows operating system, and here you have your Office software that runs Word. So we're looking at structure, basic functional connectivity, and task-related connectivity. And we're going to interrogate the brains of resilient relatives of patients with bipolar disorder to look for resilience in these 3 levels. So the way that we approached the analysis was not to impose any preconceptions. We didn't say bipolar disorder, it's a mood disorder, so we are only going to look at regions of the brain that are associated with mood. We took a very different approach, and we said we will allow the imaging data to guide us towards the regions where this plasticity is present and to extrapolate the meaning from the findings. And the first study that we published was exactly 10 years ago in 2009 in the Journal of Neuroscience, where for the first time we actually showed this structural hardwired increase in plasticity in the resilient relatives of patients with bipolar disorder. And where did we find it? In an unusual place, in the cerebellum. The cerebellum traditionally is considered a brain region that is associated with coordination in movement. But developments in neuroscience over the recent years have helped us understand that its function goes way beyond movement, and in fact, it acts to balance or to coordinate not just movement, but also actions and emotions. And so in the resilient relatives, we have an increase in the volume of the cerebellum, which seems to help regulate mood below the level of awareness. So this is hardwired regulation that does not require cognitive effort. So that's our hardware. We move now to the basic operating system. So here we asked the first question, is there any brain system that seems to be equally affected in patients and in the resilient relatives? Because we were looking for the vulnerability scar, if you want, in terms of the functional organization of the brain. And the answer that we got was, again, an unexpected one. The network that came up as being similarly affected in patients and the relatives was the sensory motor network. Intuitively, for those of you that have either experienced bipolar disorder or have experienced treating patients with bipolar disorder, it makes sense, because one of the earliest signs of changes when there is an impeding episode is change in psychomotor activity, either up for manic or hypomanic episode or down for depression, way before there is clear subjective awareness of a change in mood states. And we see this vulnerability scar being present both in the patients and the resilient relatives. We also ask the question, is there anything about the functional organization of the brain that is uniquely associated with actually experiencing bipolar disorder, not being vulnerable to it, but having it? And the answer was yes, there is a change in one other main network of the brain that is called the default mode network. This is a network that occupies the midline of the brain, and its function really is like to integrate all the information that we are processing at any given time. A way to think about it is as if it is the functional backbone of the brain. And this functional backbone of the brain in those who experience bipolar disorder seems to be slightly broken. It has lost its integration. And what about the resilient relatives? In the resilient relatives, we find the completely opposite. The backbone of the brain is more highly connected and integrated. So here we have another example of plasticity. This is long-term functional plasticity that suggests that vulnerability is associated with changes in sensory motor function, while resilience or disease depends on the integrity of the coherence of one of the core backbone networks of the brain, the default mode network. Independent of us, a Canadian group looked at the function of the sensory motor in the default mode network amongst all other networks in patients with bipolar disorder, not resilient relatives, at different types of episodes, and found that the balance between these two networks was different depending on the polarity of the episode. And we were particularly pleased when we saw this study because it provides independent corroboration of the significance of the sensory motor and default mode network, not just for resilience, but also for symptomatic expression, and makes the story about these networks more complete. And the final level of resilience is at the level of the software that runs a particular program, the task. Here we have conducted a number of studies that I will not show you all of them, I will just show you one as an example. The functional organization of the brain during a task is very fleeting. So when we have something to do, the brain regions that are supporting this particular task come together while we're doing that. So they form a task-related network, and when we stop doing this task, they stop forming that network. So here we have evidence of short-term plasticity. So we show evidence for hardwired plasticity, long-term functional plasticity, and here we have resilience-related evidence of short-term plasticity, that it's task-related. And what does it look like? So here we show the regions that are activated when people are performing a task that depends on their ability to inhibit a particular response when it's no longer appropriate. It's called the Stroop Task. And the instructions for doing this task is to ignore the name of the word, like yellow, for example, on the top line, and actually say the name of the font, so green. So as you can imagine, the automatic response is to just read the words, and this has to be inhibited in favor of speaking out the name of the font color. So the important thing is here, this is what we see in the resilient relatives. We see, and again, an increased integration within the frontal part of the brain that is actually responsible for this goal-oriented behavior of inhibiting a response when it's no longer appropriate. So we see evidence of short-term plasticity that is linked to the particular task. When resilient relatives perform other tasks, we see, again, this increased connectivity, but in other parts of the brain that are more relevant to the specific task that they are doing. So bringing it to a closure, I hope that I convinced you is the following. Resilience is actually the most common outcome of exposure to risk, and we have been ignoring that, I think, to our detriment, because it can offer very significant clues about how the brain adapts to overcome risk. We cannot remove or minimize all the risks that are around us, but we can find perhaps ways to increase our resilient plasticity. And specifically in bipolar disorder, but in other disorders as well, we find evidence of increased ability to compensate for the vulnerability scars that you can see because of the familial risk. Now, the way forward can be multiple, of course, but those are the three key questions that we hope that we'll be able to address. So we're looking at longitudinal cohorts of high-risk individuals, but also community cohorts, asking the question, do all the people that are at risk for bipolar disorder or other disorders have this resilient adaptive mechanism at some point and then they lose them as they become sick? Or is it something that the lack of this sort of resilient adaptation is very characteristic of people that are sort of destined to have a disorder, and therefore we can identify them perhaps a little bit earlier? Another, of course, avenue for research is to look for potential molecular targets for future drugs, when we're looking for the protective genes or protective molecules such as growth factors that could enhance this plasticity long term. And of course, we can target brain circuitry more directly with different forms of non-invasive neurostimulation that become progressively more sophisticated. And this can also give us a handle both in terms of prevention, but also in terms of treatment in patients that already have bipolar disorder. And with that, I would like to thank you for your attention.
Thank you. Well, you've certainly touched on something which has been touched on by several of the people. Dr. Charney, Dr. Carpenter all talked about resilience. You talked about resilience with other areas of medicine. How far do you, and you talked about it at the end, do you think we are from something which can enhance resilience in bipolar patients?
So, I believe that neuromodulation methods are our best bet in producing an intervention relatively quickly. But we need to do a little bit more, as I explained, to actually understand who has plastic response and whether there are other molecular targets for enhancing it. But my first bet would be neuromodulation, and this is one direction that we're going as well.
Very exciting and promising. Other questions? Yes, ma'am. Or sir. Sorry, I can't see very well.
Any relationship or alteration in these prospects that you've got for plasticity when somebody also suffers from forms of dementia or diabetes that is actually organically affecting this?
So my work is not on Alzheimer's disease or dementia, but the notion of cognitive reserve, brain reserve, or adaptive plasticity is something that I know other colleagues are actively exploring in the field of dementia to explain the difference in the outcomes of people that have very clear risk exposures for dementia but seem to have better outcomes than others. So not my expertise, but a field that is actively being looked at by others. The issue of brain plasticity with diabetes and other, if you want, brain energy metabolism is actually quite interesting and relevant to mood disorders. And I think probably the presence of diabetes might reduce the plastic response of many individuals. This is something that I don't have hard evidence to support now, but a hypothesis that we're actively exploring in different studies. But the good thing about this is that potentially it's something that is modifiable, that we can have interventions to correct that in people that have metabolic problems, but perhaps not in those with dementia.
Yes, sir.
Have you explored resilience and neuroplasticity is everything. A very simple approach would be promoting exercise, especially long-distance running. On a personal level, that's been critical for many of my patients and myself.
Mm-hmm. It's absolutely the case that there are interventions, there are lifestyle choices that we can make that promote the health of our brain. There's no question about that. Exercise is that, diet, of course, abstinence from alcohol and other drugs is another. But what we were trying to articulate here and is the specific mechanism that this is translated in the brain, That's exactly what we're trying to do.
Great. Last question just over here then. Thank you.
Thank you. I have a question about the possibility of suggestibility, particularly hypnotherapy as a non-invasive therapy. I haven't heard any mention of this at any of these conferences recently. So I would like to know where this comes into play, and can it be in combination with perhaps pharmaceuticals, or perhaps in a long range sociopathology in a sense of our political system.
Well, we're going to stay with science today.
I was hearing about the number of Nobel Prize winners in the Curie family. Small, but very important groups of geniuses working together, like I've heard here. But perhaps there's a lot of suggestibility in this area.
It's an intriguing, definitely an intriguing question. And personally, I would be delighted if we could use such a suggestibility to fix things in the world, because it seems like an easier solution. But I don't have any personal experience with that, so I won't be able to comment. But thank you for the question.
Wonderful. Thank you so much.